We have a few cases. So the first case is a 52-year-old gentleman, urinary intermittency, nocturia for two, 3 times a night, every 2-hour urinary frequency for 2 to 3 years, has no history of PSA screening, gets a PSA 6.1 nanograms. Per mil biopsy has 3 cores with Gleason 4+4, 4+3, and 4+3, and a variety of different percentages with associated perineural invasion. He's on Plavix with a history of an MI and 4-vessel bypass 2 years prior, and he has a urinary symptom score of 10/35, which is just a standardized way of measuring urinary symptom status. So I would ask, the surgeon unfortunately had to leave, but ask you what your treatment recommendations would be for a patient such as this gentleman.
So, I mean, I think the thing that you have to start with here is a little bit that everyone comes into cases like this with certain kinds of preconceived biases. And so the retrospective data suggesting the benefit of surgery in young patients as compared to radiation is retrospective, and there's no randomized data out there, but I do take that into account in terms of thinking about a 52-year-old. So obviously the history of MI is quite concerning, and the CABG ×4 is also quite concerning. So you just want to make sure that this is a patient who whose cardiac status is currently stable, because if he's had these the CABG 2 years prior, and he's on all sorts of secondary prophylaxis, and it's unclear if the Plavix is actually still necessary, you would just need cardiac clearance to see if surgery is safe or not. Because the issue is, if this patient were to go on radiation, at least with IMRT, for high Gleason grade in the cancer, you would recommend a long-term hormonal course also with radiation, which, as we know, also has cardiovascular toxicity. So I don't feel like either option is without potential toxicity for this gentleman. So it's just a question of, does he have active cardiac issues now that need to be addressed before either intervention? And then what are his potential oncologic outcomes versus one or the other. So, and in the end, it would have to be a bit personalized to, what this guy's actual performance status is, and what his, baseline functioning is, and what he hopes to achieve after the outcome. So it's hard to say that there's one that I would recommend much more strongly than the other, but I think you just have to talk about the risks in a lot of detail so that this gentleman can make an appropriate decision for his needs.
Yeah, with a gentleman like this, we would talk about surgery as an option. We would talk about one of the radiation approaches, which would be either external beam radiation with IMRT, or a combination of external beam plus radioactive seed implant, or proton therapy. And we would normally, with high-risk disease, talk about combining with the hormonal therapy. Perhaps in a patient like this with this kind of history, we might think of abbreviating the hormonal therapy to 6 months as opposed to a longer course to try to decrease that exposure somewhat. But he does not look like he's at high enough risk that we would irradiate the pelvic nodes in a patient like this, but we base that on actually looking at the Memorial Sloan Kettering nomogram to see whether the risk is 15% or more for lymph node involvement. If it were, we would include the pelvic nodes in the initial portion of the treatment, but I wouldn't expect that to be the case in this patient.
So he actually refused neoadjuvant and concurrent androgen deprivation therapy. And I would agree, I wouldn't normally treat the pelvic lymph nodes, but since he was refusing hormone therapy up front, I was a little bit more worried about progression. Did go ahead and treat the pelvic nodes in addition to the prostate. And we saw a good decrease in his PSA immediately after treatment. About 3 months was 1.4, then declined over the next 3-month intervals, and then started slowly rising again. And so this is a twofer, same patient, 2 clinical questions. When do you act on the rising PSA after definitive treatment?
So I wouldn't act now, for one thing. But one thing that is being piloted and being considered in this population is a consideration of salvage surgery for radiation failures. It's, our urologist isn't here, so he's not here to talk about all the different complications and difficulties of considering that approach. But in a patient who's young, granted he has a lot of comorbidities, we're piloting the idea of doing MRIs and such in a patient like this to see if there's a nodule or something locally that is likely to be the source of this PSA, because the problem is that you don't know if this PSA is due to local recurrence or systemic recurrence, and there's no imaging modality that is sensitive enough usually to pick that up at this time. So if your PSA gets to around this level, as you know, in the trials for recurrence after radiation, they usually kick in after the PSA is greater than 2 over the nadir. So he wouldn't, by clinical trial criteria, count as radiation recurrence until the PSA is 2.6. And so at that period of time, I might, if this patient would be a surgical candidate, I would think about doing some systemic imaging to see if he has a low PSA producing tumor that might actually have bony metastases that are seen on bone scan at this point, and an MRI to get an idea if this is systemic or local recurrence. But if you don't see anything on either imaging study at that point, then you have to think that it might be just disseminated recurrence, and then I would keep following the PSAs and get a sense of the doubling time. And this was a question that was brought up earlier. So I've polled all the senior physicians at Dana-Farber about what they think is the right threshold for initiating therapy if it's all systemic disease. And Dr. Sweeney had a idea that seemed reasonable to me. It's just, in all patients, let the PSA get to 4. And once it gets to 4, you will have enough data from the previous measurements to know what their doubling time is. If the doubling time is short, a year or less, you might think of starting therapy right then. But if the doubling time is more prolonged than that and they have no macroscopic systemic disease, you might wait until the PSA gets to 10. But you probably wouldn't wait much longer than that.
Yeah, the other thing that when we have patients that have a PSA that's rising and approaching, say, if you were to approach a 2-point rise above the nadir, we also will look at those patients in terms of, could this be a possible prostatitis? And some of the we try to always pay attention to the patients have a history of prostatitis. Do they have acute or chronic inflammatory changes on their biopsy at the time they had their prostate biopsy for establishing their diagnosis? Even if they don't, they certainly could develop a prostatitis following placement of the gold marker seeds for the procedure that we're going to do. And so we will, because the implications of declaring them a treatment failure are potentially so great, we will put them empirically on a course of antibiotics and repeat the PSA after a month and see if it comes down. And we've certainly seen that in enough patients that we standardly do that before we assume that it's a failure. And then if it does appear to be a treatment failure, then we will go from that point to doing an MRI and a bone scan, a PET bone scan, and looking for, is this a local failure or is this a systemic failure? And we have occasionally seen patients who failed in regional nodes where we've come back and irradiated for salvage for the nodal failure. We have an ongoing oligometastatic program for patients who have limited metastatic disease that have 5 or fewer sites of disease that they may be a candidate for enrollment on that study.
Fantastic, thank you. We have a second case, a 72-year-old gentleman. He had a PSA of 4. had been rising slowly over the previous 3 years from 2 to 3.85 to 4. He was biopsied, had Gleason grade 4 plus 3 equals 7 on the left and 4 plus 4 equals 8 on the right. He had a CT of his abdomen and pelvis that showed a 4 by 4 centimeter prostate, no adenopathy, some small sclerotic foci in the sacrum that did not correlate with bone scan, so it was presumed bony islands. Again, this is more of a upfront question on therapy, but get your input on if you would treat this patient any differently than that first patient.
I mean, this patient is 72 and the other patient was 52, but if this patient doesn't have any comorbidities, he actually might be a better candidate for both modalities of therapy than the initial 52-year-old, because there are many 72-year-olds who have an expected life expectancy of 15, 20 years or more. And so I wouldn't use the age as a cutoff for anything in particular. The one thing that hasn't been brought up in terms of the radiation versus surgery discussion is that, for patients who get surgery, but they have extensive disease, T3 disease, or meaning extracapsular extension, seminal vesicle invasion, we would often recommend adjuvant radiation. And at different institutions, that adjuvant radiation is often given in combination with hormonal therapy. So there are some people who think that if you think a patient is likely to have T3 disease, that you shouldn't necessarily offer them surgery because they're going to need the radiation anyway. The part that we don't know and we would like to study is whether actually combining surgery with adjuvant hormonal therapy and radiation is actually superior to radiation and hormonal therapy alone, but we have no idea of the answer to that. That's a very, very controversial point. So often in these patients, we'll actually get an MRI, and the MRI will give us a radiographic sense if there's T3 disease. And if there's not radiographic T3 disease, I think surgery and radiation are both on the table, and the oncologic outcomes in this range are quite similar. If there is T3 disease, some people would advocate going to radiation to exclude the potential toxicity of surgery, given that you're going to need adjuvant radiation anyway. But some people advocate for trimodality therapy for trimodality therapy's sake, for just possibility of increased efficacy, even though there's no data to suggest that.
And that sounds like the conversation I have with my urologic oncologist not infrequently.
Yes.
He would favor doing the surgery and adding the radiation, just knowing up front you're going to need that. And,
right.
And we would lean the other way, but we actually need data to help resolve that difference.
But that segues right into our next case, which is a 61-year-old treated with robotic prostatectomy, Gleason 7, then pretreatment PSA of 5. Had positive apical margin at the cautery edge of the seminal vesicle, continued to be Gleason 7 disease with the largest nodule of 1.7 centimeters, with a post-surgery PSA of 0.6 that then later increased to 0.8 at 2 months.
I mean, in my mind, this is a reasonably straightforward case. This is actually post-surgical salvage, which
right.
We would do radiation, and at our institution, we would combine this with hormonal therapy. And the question that sometimes comes up is how much hormonal therapy would you use in a salvage kind of context? For a Gleason 7, I think 6 months is totally adequate. The only sort of randomized study that we have with radiation plus hormonal therapy in the salvage setting is 2 years of high-dose bicalutamide. Seems to be better than no hormonal therapy alone, but we don't use high-dose bicalutamide as hormonal therapy because it's quite toxic. And so it depends how you feel about that data. The way that we've written our guidelines is 6 to 18 months of hormonal therapy in the salvage setting. And so for a Gleason 7, I would probably favor the 6 months. But if this was Gleason 8 at the margins, you might think about a longer course of hormonal therapy.
Yeah, and we would offer salvage radiation for this patient on protocol, and we typically treat the prostate bed to 70.2 unless we can demonstrate on imaging that there's some residual disease or recurrent disease, which we would boost another 3.6. Also, if there's Gleason 8 or a pre-surgery PSA of 20 or more, or seminal vesicle involvement, then we'll irradiate the pelvic lymph nodes in addition and add hormonal therapy.
I want to thank our speakers.
Thank you.
And, I'll just go to the last case, which is not really a case for discussion so much as a case for education. And it's a 52-year-old gentleman who, you'd think he'd be a fantastic candidate for surgery. Low intermediate risk disease wouldn't be a good watchful waiting candidate. But he absolutely positively did not want surgery because he was a widower who was raising 3 daughters pretty much by himself. And he couldn't justify being in the hospital for 1, 2, or 3 days away from his daughters without support. So he said, I can easily come in every day for 15 minutes, but I can't be away from home for even 2 or 3 days. So it is, it's hard for the clinician because the most important question I ask, and probably all of our speakers ask, is, what do you like to do? Who are you to our patients? Not all the symptom questions that we normally ask patients, because what we recommend ultimately is could significantly impact their quality of life, and knowing what is important to them is going to determine that. So thank you again, and thank you everyone for coming.